This slide's presentation will give some general information about things to consider in both transtibial and transfemoral sockets and the fit of that socket on the patient. In general, when the prosthetist is designing the socket, he has a couple of goals in mind. General goals for both transtibial and transfemoral sockets include contouring the socket for functional muscles. So, for example, in a transfemoral socket, the prosthetist wants to ensure that the adductor muscles have a space in the socket and can be used when the patient is using the prosthesis. Secondly, the prosthetist wants to stabilize skeletal structures. Example of this would be with a transfemoral socket. The prosthetist tries to stabilize the femur by incorporating part of the ischial tuberosity or by choosing a socket suspension that's going to help keep that femur relatively vertical. Finally, they want to distribute forces over the wide area. This is going to be true for both transtibial and transfemoral. Different kinds of socket designs that are used for each of those. However, you don't want the socket causing undue pressure on only one part of the residual limb. As far as transtibial sockets are concerned, there are something called pressure-tolerant areas on the residual limb, and these areas can tolerate pressure. Then there are pressure intolerant areas, and the prosthetist is going to design the socket so that there's reduced or no pressure in these areas on the residual limb. And then finally, the patient as well as you should monitor for volume changes in the residual limb. And these volume changes can fluctuate during the course of a day, and the patient might actually need to add and subtract socks. This slide shows the pressure tolerant areas. Okay, what you see here, so on the far left-hand side of the slide, you have the anterior view of a transtibial residual limb. And on the right side of the slide, you have a lateral view of a transtibial residual limb. The areas that are shown in a green color are pressure tolerant. That means that the prosthetist, when he designs the socket, he designs the socket so that it's putting pressure on these particular areas. Particularly important to note here are the supracondylar or suprapatellar areas indicated by numbers 11 and 12, as well as the patellar tendon. Okay, this slide shows the pressure-sensitive areas. The pressure-sensitive areas are shown in red, and the most important thing to consider that you want to keep pressure off the fibular head. Okay, you don't want any pressure on the residual fibula or tibia. You don't want pressure on the patella or the medial or lateral femoral condyles. I like this picture because when you look at a patient after they've removed their transtibial prosthesis, if you see redness in any of the areas that are indicated here, that's a sign that you want to call the prosthetist and see if they can change the amount of pressure in that area. Okay, this is Dr. Ustahl again, and I'd like to just watch his video.
Hey, welcome back. It's Dr. Ustahl here again. In this segment, we're going to talk about below-the-knee prosthetics, and specifically about the socket, the part of the prosthesis that goes onto your leg, the part that's custom-made, that acts as the connection of your body to the prosthetic foot and eventually to the ground. There are several different parts and several steps along the way, so I'm going to explain each one as we go and some of the problems that you can have with each one. So first, let's talk just a little bit about material and what we call these things. The socket itself is this piece from the connector up. This is the part that's custom made, and you see that there are contours to it. It's shaped to match your limb, but it's also shaped to put more pressure in some areas and less than others. So you see how there's a bump here, and that indentation should go right under your kneecap, we'll call the patellar tendon. It's the same place that you put pressure when you kneel down. So you put a little bit of extra pressure there because your body tolerates pressure there. We also try to grab the sides of the bone in the leg called the tibia, because that will tolerate pressure. We want very little pressure on the bottom of the cut end of the bone, so we want to have a little bit of extra space or cushion in there. This outer frame of the socket is typically called a laminated socket. There's a dark line here because this is carbon fiber lamination. Layers and layers of carbon fiber put over the mold of your leg. That then creates a very strong, very hard, but very light prosthesis. Amputation below the knee, typically the part that is removed might weigh 8 to 10 pounds. The prosthesis should be about half of that, about 4 to 5 pounds. So the outer frame is what really provides most of the structure and support. But your skin wouldn't tolerate going directly into here, so we have to have a soft interface, a material that cushions your skin, your tissue, to this hard outer shell, and also provides a way of holding on to you. And that holding on process is called suspension. So sometimes the interface material gives you cushion and suspension together. Sometimes it's two totally separate pieces.
Okay, back to me. You should know that there are two main transtibial socket styles, and that's shown on this slide. The one on the left, and here you're looking at the lateral view of a transtibial amputation, is known as the patella tendon bearing. Okay, the patella tendon bearing socket, you can see it has that specific cutout right in here, just under the kneecap, that's concentrating the force on the patella tendon, since it's such a good weight-bearing structure. The other is the total surface bearing socket, and the total surface bearing socket doesn't put any specific pressure anywhere. It does avoid pressure on those pressure-sensitive areas of the residual limb, and the patella tendon bearing prosthesis is highlighted in red since it's the most common type of transtibial prosthesis that you'll see. As far as transfemoral socket considerations, you want the femur stabilized against the lateral wall of the socket. Remember, this is going to be important because if the patient has a relatively short, or the shorter their transfemoral amputation is, the more adductor mass is going to be removed. So you want to make sure that the femur doesn't stick out into abduction. Other things to consider, just like transtibial, you want to monitor volume changes in the residual limb, which might mean that more socks or less are needed throughout the course of the day. Now, with the transfemoral socket, there should be total contact between the residual limb and the socket, and there should be no weight bearing on the distal femur. You can monitor to see that if this is true with something known as a test socket or a check socket, and this is shown in the picture on the right hand side of the slide, where it's just clear, and you can see that the distal femur is not any weight bearing in the socket itself. The only exception to this is going to be your knee disarticulation. Remember, your knee disarticulations and your SIME amputations are going to be weight-bearing amputations. This slide just shows the pressure-sensitive and pressure-tolerant areas for a transfemoral amputation. And again, the far left is the frontal view, and then you have the lateral view in the middle. The pressure-sensitive areas are indicated in red, and pressure-tolerant is indicated in green. And just similar to the transtibial areas, you want to make sure that there aren't any red spots from the prosthetic after wear in a pressure-sensitive area. Okay, there's another video with Dr. Ustall.
Hey, welcome back. It's Dr. Ustall again. Today's segment will cover prosthetic socket design for amputations above the knee, what we call AKA or transfemoral, above the knee amputation, so somewhere between the knee and the hip. Typically, they try to preserve as much length as they can with a fair amount of muscle covering that, so generally longer amputation limb is better. The part that goes onto your leg that holds onto you is called the socket. And so let's talk for a few minutes about how that socket is designed. All sockets are made from a casting or molding of your leg, so the prosthetist would use fiberglass or some kind of electronic scanner to duplicate the mold of your leg, and then from that mold, build the socket. The The socket is the top piece here. It's custom molded to the shape of your residual limb or your amputation limb. The key thing is trying to figure out where the pressure goes. Unfortunately, because the femur bone is the primary weight-bearing bone of the thigh, is cut partway down, you can't really put any pressure on the end of that bone. So we have to bring the pressure way up here to typically the bones that you would sit on. When you're sitting down, you're sitting on a special bone called the ischium and the muscle over it called the gluteal muscle, gluteus maximus. So we use the same kind of idea here that we try to capture that ischium bone that's way up kind of on your butt and then the muscle on your butt to take the pressure. So when we look at an amputation prosthetic device like this, here's the front, here's the back, here's the inside towards the groin, and the outside. So right back here is a special piece that's designed to capture that ischium bone. The ischium, the bone you sit on, slides down inside. This kind of goes right up to the groin. So this is kind of a delicate area for all of our patients with amputation above the knee. This is the primary area for complaints and concerns. You can't trim this too low because if you make it too low, skin and tissue starts to fall out and then it rubs even more underneath and makes more irritation and problems. So we try to bring this edge, this inside edge by the groin, as high as we can, but then we roll it down and keep it smooth. The rest of it really is capturing the limb, preventing the limb from kind of wobbling or moving too much. This is intended to be a nice snug fit. There's almost always a flexible plastic inner shell and then the hard outer shell. The hard outer shell is a carbon fiber lamination. There's a black line that you can see in the socket itself, and that is the carbon fiber, layers and layers of carbon fabric to keep it strong and keep it light. But the inner material is meant to flex a little bit, particularly at the edges, and allows us to take this out, make some adjustments, put pads and things in there.
Okay, moving on to transfemoral socket styles. The kind of socket that Dr. Ustall was just talking about, and the most common socket type that you'll see out there is known as the ischial containment socket that's shown in the middle of this slide. Approximately 85% of the transfemoral prostheses out there are ischial containment. And here the femur is held in adduction just by the way that the socket is shaped. It's a very intimate fit, and it sort of has a triangular looking shape if you look at it from above. An older socket style that you will see pretty rarely is the quadrilateral socket. This used to be the most common. It has 4 well-defined walls, which gives it that rectangular or quadrilateral shape. It also has an ischial gluteal weight bearing, but because of the lack of stabilization in the femur, it's not such a good socket style choice. And then over on the far right, there are other socket styles, which we'll just call direct sockets or brimless sockets as they can be known. Again, this is relatively rare, and it's typically used with some sort of vacuum suspension or suction. Okay, and what happens here is that it's the pressure from the vacuum or the suction that actually holds the femur stable. Moving on, here's a basic prosthetic wearing schedule. Okay, the numbers that you need to remember are 2 to 20. So this would indicate when the person first starts wearing the prosthesis, whether it's a transtibial or transfemoral, they should have 2 hours of wearing time. During that 2 hours of wearing time, they should have no more than 20 minutes of total weight bearing per hour. So during those 2 hours, they'd have 40 minutes of weight bearing time. They'd also, after that 2 hours is over, have 2 hours of off time. And then to progress this, you want to add an hour of on time every 2 to 3 days if they're not experiencing any problems with the prosthetic. And here's one last video to give you more information about a prosthetic wearing schedule.
Now we're going to talk about wearing schedules with the prosthetic. Every patient wants to get that prosthetic, put it on, and if it's not uncomfortable, they want to get up and they want to walk and they want to leave it on and just wear it all day long. That's a very bad idea. We have to be very careful. It is important to remember if you look at the tissue on the middle of your shin or the middle of your thigh, It is not like the tissue on the bottom of your foot. So it has to have time to adapt and become capable of absorbing the pressures and shear tension that's going to be on the skin. So we want to give the body time to develop a tolerance and a tensile strength to be able to absorb the energy that's going to come through the prosthetic device or the weight or the pressure. So really important, the skin is different and the wearing schedule has got to be something that you closely adhere to, especially with your diabetic patients. Diabetic patients who have sensory neuropathy issues and don't have good feeling can oftentimes go into a prosthetic device and say, well, it feels great, and not realize that they cause a lot of damage until it's already done. When people ask me, can I be more aggressive with above the knee or below the knee patients as far as the wearing schedule? And honestly, you can be much more aggressive with the above the knee. Sometimes that sounds funny, but you got to remember most below knee amputees can damage themselves before they hurt. In other words, that pressure right at the bottom of the residual limb here in the socket may not have good sensation of before they actually have done skin damage or worse. On the above knee amputation, what you're going to have is pressure high up into the groin if you get too far into the socket or the place where the socket's not fitting. And even high up into the groin in a diabetic patient, there's usually pretty good sensation. So they'll usually feel the pain and the pressure before they can really hurt themselves. Where on a below knee, it's the opposite. And you must educate your patient to take the time and inspect the limb and look at things and don't trust what you feel. So what kind of wearing schedule do I use? I love the 2-2-20 system. That's a system I've used for years and it really works well with most patients. That means wear the prosthetic for 2 hours on, and then take it off for 2 hours, and no more than 20 minutes of weight-bearing time per hour. So you don't want to put it on and walk around for 2 hours. 5 minutes here, 5 minutes there, for up to 20 minutes per hour. Remember, there's benefit to having the prosthetic device on, even if you're not up and moving. Just simply having it on is helping your brain reconnect with the ground and feel that there is something down there that I'm going to be working with. As we're remapping the brain, that's important to have that information for your brain to work with and feel comfortable with. So the system is 2 hours on. At the end of that 2 hours, you want to take everything off, the socket, the liner, the sleeve, everything. Closely inspect the skin. If you have good vision, then that's really helpful. But if not, you may need someone to help you, or use a mirror. Sit in the wheelchair, roll up to a mirror, use a hand mirror to look all the way around the residual limb for any spots of irritation. Many times there's going to be some pink areas on the skin. That's normal because there's pressure. As soon as you look, as long as there's no areas of drainage, there's some pink spots, you want to immediately put your shrinker back on. By immediately, I mean right away, not in 5 or 10 minutes, because there's going to be rebound swelling that's going to occur as you come off of the prosthetic use from the pressure that you were on. So put the shrinker on immediately, leave it on for 2 hours. At the end of 2 hours, take it off. If all the pink areas are gone and it looks back to where it was, you're ready to put the prosthetic back on again. If something looks worse, more irritation, more red, you want to leave the prosthetic off until you talk to your therapist, your doctor, or your practitioner. But in most cases, you'll find you can put it back on and then build that schedule. How do you build a schedule? I usually add an hour of on time every 2 to 3 days based on how someone's doing. So then go to 3 hours on and 2 off, 4 hours on, 2 off. Once you get to there, you can really go to 5 and 1, and then patients most likely within 2 to 3 week period can be up to wearing the device all day. So with prosthetic fitting and a wearing schedule, one of the things that's very important to not forget about is the contralateral limb. Oftentimes, the patient's contralateral limb, especially if they have vascular disease or an older patient, has more potential compromise than the residual limb. If the surgeon got the amputation at a good level, they're more likely to have an amputation on the contralateral limb if it isn't cared for correctly. And that means you have to monitor it closely as you go through the wearing schedule and they're getting up on the prosthetic, closely keeping an eye on skin inspection all the way down through for marks, irritations, swelling around the ankle, things in which you can use a compression sock for or a TED hose, those types of things. But the other aspects of things, how can I help that foot out? Because honestly, the foot on that side, I like to say to patients, sounds a little corny, but you want to think of your remaining foot as it's made of gold. What does that mean to you? Gold's very valuable. You want it. But gold's not a very strong metal. You're not going to build a building out of it. You have to really care for it and treat it accordingly.